with all relevant healthcare providers, institutions, and organizations. 3, avoidance of the overuse of drug and technology, such as oxytocin, augmentation, episiotomy, cesarean section, and so forth. That was given a 2. Avoidance of detention in facility due to lack of payment, 1. Prevention of institutional violence against women and newborns, including disrespectful care, 3. The main source of funds used to support the implementation of strategies or interventions or any activities related to humanized, respectful maternity care in the country, that is St. Lucia, that was government. And there were options there that were not identified by the participants, and that is non-governmental, non-profit, private sector, and others. They were not identified. The main results achieved on the work developed in the country, well, here you have it: improvement in healthcare and management of the client, improved confidentiality and respect for clients. The main tools and resources used to implement the strategies or interventions or activities. The activities that we used were workshops, videos, brochures, and lectures. The main challenges faced as reported by these midwives, the main challenges faced in the implementation of these strategies were lack of knowledge on what constitutes maltreatment of maternity care, and you can well realize most of the countries are reporting that. Information learned from workshop is not being practiced by all participants, so they learn and they don't practice what is being taught. Lessons learned from the work done to support the implementation of RMC in country at St. Lucia. Being aware of the many varieties of maltreatment that exist, they are not aware of that. The need to continuously monitor the progress of the programs and the evaluation of the work done to measure success. That's the lessons learned. Recommendation to countries, institutions wishing to implement strategies, interventions, activities to promote humanized, respectful maternity care, as reported by the 3 interviewees, were: 1, develop policies and guidelines to guide practice, conduct regular in-service sessions to address RMC, evaluate policies to ensure that they are being adhered to. We were asked to maybe talk about how COVID has impacted on RMC in St. Lucia. And this is the result from the 3 midwives that I interviewed. Women are required to wear a mask when seeking health care to adhere to protocol, even if they want to or not. So that is impacting on the choice or the decision on that, of that client. Social distancing may be misinterpreted as a healthcare provider, unwillingness to make physical contact with the woman. So the social distancing is sending out a negative image. Inability of the healthcare provider to assess facial expression. As you know, as midwives, we need to assess our clients' facial expressions when we assess them, because that speaks to the comfort of the client, some kind of communication to the midwife. Wearing of mask may interfere negatively with breathing exercises in labor, and I'm sure persons who have had babies, they will realize if you need to do any kind of breathing exercises, the mask is going to be a deterrent in doing that. Limited maternity care due to staff constraint from COVID-19, leaving the pregnant woman or the woman and her baby at risk for complications. Restricted visitation for hospitalized women, increased use of personal protective equipment, PPE. Of course, there's an increase in that. And here ends my presentation. I thank you very much for your attention. Kafian.
Thank you very much, Ms. Ernest. Ms. Henry Ernest, sorry.
Yes.
So moving right along, we are going to invite Ms. Carol McKay to present the perspectives from the Bahamas.
Diana, can you take down your PowerPoint?
Sorry about that.
Is my screen up?
Yes, it is.
Yes, we can hear you and see you. Go ahead.
Okay. Good night to everyone. And I am Harold Mackey-Mizik, and I am presenting the findings of the RMC survey that was done in the Bahamas. And so for my overview, I would be looking at outlining the process for the selection of the interviewees. I would review findings of the survey, highlight key areas of the interviewees' responses, and outline the effect of the COVID-19 pandemic on respectful maternity care. And so here in the Bahamas, in this presentation, we will review the responses of 3 midwives that were interviewed here in the Bahamas. For the participant selection, the persons chosen for the interview were contacted for permission. Prospective participants were briefed on the purpose of the survey and was asked if they agreed to be interviewed. Once the individuals said yes, a date and venue was agreed upon for the interview to take place. All persons who were asked agreed to participate, and the letter of explanation was given to each participant. The interview process took an average of about 45 minutes to an hour and 10 minutes. Each interview took place in the participant's office where they worked, and the participants answered all of the questions presented to them. So the persons that were interviewed from the Bahamas included a nurse administrator from the Department of Public Health. We had another nurse administrator in charge of one of our polyclinics, who is also a nurse practitioner. And the third person was the supervisor from the maternity ward. So overall, questions in this, what I will be doing is looking at the overall questions which directly relate to respectful maternity care from the survey. And so I will begin with question number 1. And in question number 1, it addressed reports of mistreatment of pregnant women. Now, 2 of the interviewees had said that they did not feel as if there was abuse of maternity clients. However, this was the responses that were given when each one of the questions were directly addressed. And so the responses for question number 1 included lack of privacy, lack of confidentiality, verbal abuse, denying liberty of movement during labor, denying choice of position for delivery, discrimination based on race, and unnecessary separation of mother and newborn after the delivery process. For question number 5, this question addressed the underlying factors for disrespectful and abusive maternity care. So the responses here included a lack of knowledge and awareness, so meaning that the midwives were not aware that some of the areas were actually categorized as disrespectful maternity care. They also said that general attitudes of healthcare workers, and so some persons just had a poor attitude towards their work and what they were doing. Infrastructure of the setting, persons stated that because of how the units are set up, this lent to a lack of privacy and a lack of confidentiality due to the limited space. And in some spaces, you will have 2 clients and 2 midwives. And so that lent to a lack of privacy and a lack of confidentiality. They also stated overcrowding, and that also related to the infrastructure not being large enough to accommodate all of the clients that present themselves. Language barrier in terms of the midwives being able to effectively communicate with clients whose first language was not English. A shortage of midwives, which resulted in midwives becoming burnt out, and institutional policies that guide care. And so when we look at the institutional policies that guide care, it was stated that there is an institutional policy that clients who come into labor, once they are in established labor, once they are actually on the labor ward, they are unable to have anything to eat or drink. And so policy states that they must remain NPO during the process of labor. Also, in terms of visitation, persons are unable to have their significant other or a relative with them while they are in labor. And that again is due to the institutional policy. So some of the areas that were stated on the survey as areas for disrespectful maternity care, the midwives or the individuals were unable to do anything about it because they were being guided by institutional policies. Question number 6 addressed strategies to address respectful maternity care. And when asked these questions, all of the interviewees said that there were no strategies identified at the country level that addressed respectful maternity care. However, when we looked at the institutional level for the Department of Public Health, one of the interviewees stated that there was a customer service training program for all staff. So all staff members were mandated to attend this customer service training, and it focused on training staff to be receptive to the clients and communication skills. They also offered a course in Creole, and so this was to assist with the staff being able to better communicate with clients that are Creole speaking clients. They also implemented a midwives team, and the midwives team consisted of about 4 to 5 midwives, and what they did was they rotated all of the different clinics, and they would assist with seeing the maternity clients. So what this did was this helped to improve the amount of midwives in that particular clinic in order to be able to see clients in a more readily manner. For the maternity unit, one of the strategies that they looked at was customer service training for midwives. And so the individual said that they were planning a training session for midwives, and that would focus on improving customer service. For question number 7, this question addressed strategies, interventions related to humanized, respectful maternity care promoted in country or area of work. Again, all of the interviewees stated that there were no strategies or interventions identified at the country level that looked at humanized, respectful maternity care. However, when we looked at the work area for the maternity unit, interviewee stated that a customer service survey was done in 2018 to gather data on the client's perception of the care received while on the maternity unit. They also implemented quality service improvement project in 2018 to improve bed space on the antenatal unit. And what they did was they renovated part of the antenatal ward, and that provided an additional 6 beds so that patients would not have to wait extended periods for bed space. They also implemented a day assessment unit, and what they did with this day assessment unit was that prior to the day assessment unit, all patients coming to the hospital, all maternity patients, had to be seen through the labor ward. So whether they were actually in labor or they were sent for a non-stress test, whatever the problem, everyone went through the labor ward and had to be seen. And so what that did was that caused excessive amount of clients on the labor ward, and it limited the space for the patients who were actually in labor. So the implementation of the day assessment unit, all patients who were not in labor were referred to the day assessment unit, and they were seen in that unit. So that allowed the labor ward to only see patients who were actually in labor. So that was able to free up some space and alleviate the backflow of patients that were being seen. So in terms of policy for the findings, policy related to respectful maternity care, all of the interviewees stated that there was a lack of national policies to address issues related to maternal and child health, respectful maternity care, and also that there was a lack of involvement of midwives at the policy making level. So policy was one of the key areas that was identified in the survey. So common findings that we came up with: there is a shortage of midwives that contribute to midwives becoming burnt out. The burnout affected the attitudes of the midwives towards clients, and the structure of the public setting presents challenges with privacy and confidentiality, and also again, language barrier. They also stated that laboring patients were not able to have family support and freedom of choice in their laboring process. Limitations that we found: individuals were being able to, it was a challenge in them being able to remain unbiased in providing information. There was concerns for the country being highlighted in a negative way. The tool focused on persons at the administrative level, which limited the use of persons in direct contact with maternity clients. And also it was a small amount of interviewees that was used for the survey. So we were asked to address respectful maternity care in the light of the COVID-19 pandemic. And we were asked to look at the effects of respectful maternity care on the effects of COVID-19 on respectful maternity care. So the areas highlighted: the number of midwives have been impacted, and so we had midwives who were exposed and as a result had to quarantine, so that caused the number of midwives to be reduced. Lack of knowledge re the spread of COVID-19. As a result of this lack of knowledge, you had fear of exposure, which contributed to midwives being uncomfortable sometimes with managing the clients. The postnatal services, the midwives working in postnatal services were no longer going out to see patients, so they were doing phone calls. And so that interrupted, the COVID-19 interrupted the postnatal services, not allowing them to see their clients in the home. And we also have had women, the clients themselves, the maternity clients themselves, some of them voiced the concern now of having to come into hospital in the era of the COVID-19 because they were in turn fearful of some exposure. And so in summary, we stated the common findings in the survey was a shortage of midwives, which led to burnout, inadequacies in the infrastructure of the clinic and hospital setting, the lack of country and institutional policies related to respectful maternity care. And so we can use the findings of this project to formulate strategies to address changes in our healthcare system that will seek to improve care given to our maternity clients and their families. And I just want to acknowledge and say thank you to the persons who took part in the survey, and I want to thank you all for listening.
Thank you very much, Ms. Carol McKay-Missick. At this point, we have the perspective from Trinidad and Tobago by Mrs. Marcia Rollock.
Okay, just give me a minute. I will stop my sharing.
Sure.
Good night all. I am going to do the perspectives from Trinidad, for the survey from Trinidad. And so the survey, this is the Trinidad report of the survey done for the respectful maternity care. And as we heard before, the purpose of this survey was to assess the views and experiences of selected midwives on the topic of respectful maternity care. The survey was conducted using an interview guide that was previously piloted. And as we heard before, it was divided into 14 questions to allow for the data to be gathered on all areas of respectful maternity care. The methodology: respondents were interviewed via telephone and face-to-face, and the interviews were generally conducted within 1 hour. The interviews were done with a representative of our Ministry of Health, with a healthcare worker who is community-based, and with a healthcare worker who is based in an institution. The findings of the survey, similar to the other countries, we found that there was a lack of evidence-based care. There were no or few updated practices or policies, and normally as the management, some of the management, as we said, were routine, so that a lot of the practice or few of the practices were not updated. There was a lack of accountability, particularly at poor documentation. It was found that there was poor infrastructure in some of the areas. Understaffing, the cry from everyone, I think up and down the Caribbean, is the limited number of staff. There was also a fear of change, in that some of the midwives were accustomed to doing things a certain way, and to change in what they were doing posed a bit of a challenge. There was limited monitoring, and also one of the things that came up was that the public, the interviewees felt that the public was not demanding respectful care when they went into institutions. The challenges that they found were lack of knowledge of respectful maternity care, again, staff shortages, poor time management, and uncertainty as to the midwife's role in respectful maternity care. Similar to the other presenters, it was taught in the classrooms or in the beginning pre-service, but a lot of the midwives didn't recognize their role. And some of the items that they had identified, they did not recognize them as being mistreatment of clients. Another challenge they found was poor interprofessional and multidisciplinary relationships, where they found that the midwife wasn't treated the way she should be treated when it came to respect from her colleagues. Some of the strategies and interventions: improved childbirth classes in all the RHAs, the provision of fathers and support persons with the woman during labor, the use of tools and resources such as visual aids, current literature, drills and skills training, and preceptorship for students. Some of the results of the use of these strategies: they found that they had better informed clients, properly prepared staff, improved birth outcomes, increased breastfeeding rates. And this was because of the intervention of increased skin-to-skin contact within half an hour after delivery, and the early initiation and the breastfeeding. These sought to increase the breastfeeding rates. So we found that the strategies at least yielded some results. The main lessons learned: they all said that the respectful maternity care is a long-term work, and that there was no quick fix, and that it meant that there was a lot of interventions to be put in place over the long term so that the respectful maternity care becomes a reality and the midwives recognize respectful maternity care as an issue. Training also was of the utmost importance, so that the midwives in training would be trained with the respectful maternity care strategies, and also they noted the importance of preparation for childbirth, better preparation of staff, so that if the training is done, then we would have better prepared staff to be able to deal with our clients when it came to respectful maternity care. And also we would have a better public, better informed about maternal and child health. So the respectful maternity care, they all agreed, would be beneficial to the long-term care of our clients. The recommendations that they had coming out of the survey was that there was a need to engage professional organizations, for example, the midwifery associations, to help, with the upgrading and the continuation of the training for midwives, with updates on respectful maternity care. It was also recommended that what was needed was a multidisciplinary approach. So just not only the midwives looking at respectful maternity care, but also the other disciplines in the care of the woman. Another recommendation was the competency-based educational sessions for community staff, and particularly to help with the recognition of the mistreatments that women endure. And I must say this is one of the aspects that in Trinidad that we are planning at the level of the Ministry of Health to have the CBE educational sessions for the community staff. It was also recommended for improved staffing, and improved staffing, the interviewers recognized not only midwives, but improved staffing all around with all categories of staff that assist with women in maternal and child health. They recommended also the shift of the focus to educating the clients and families, which of course will give you a better educated public, and also monitoring and evaluation workshops for respectful maternity care. So they recognize that with the awareness of the respectful maternity care, what would be needed would be monitoring and evaluation workshops to ensure that the end product is achieved. They also recommended adaptation of infrastructure to facilitate a positive pregnancy, labor, delivery, and birth. And because the interview was done with leadership as well, so we can see that some of these recommendations would be able to be implemented. The effect of COVID on the respectful maternity care. COVID caused limited access to maternity services, partly because of lockdown in some areas, and partly because of fear of persons not wanting to go into hospital because they're afraid of contracting COVID. It also caused decrease in the planned care for sexual and reproductive clients, because when it came to the issue of their supplies and so, COVID had an effect on that. Restriction of the support person in labor. We recognize that some of the in the initial stages of COVID, some of the hospitals limited the support person in labor. That has, however, been corrected, and so we have support persons supporting their significant others during labor. Separation of mother and baby, again, because in the earlies, with the uncertainty about this COVID-19 and the spread and the transmission, mothers and babies were separated, but again, that has been rectified. Rationing of PPE as one of the reasons for the restriction of the support person is that the PPE would be needed for staff. Again, all of that have been changed now with the advent of more PPE in circulation. And of course, because of the COVID-19, we would have had burnt out by maternity staff, because we had some of our staff coming down, if not positive, but in quarantine, which created a significant problem as well. So measures to deal with the COVID, establishment of protocols and procedures, and like everywhere else in the world, it is a new emerging disease for which we are still finding out. So there needs to be set protocols and procedures. The use of technology is one of the good plus signs for COVID, because we now are able to do childbirth classes via Zoom, as well as some areas using the telephone, and so to keep up to date with the patients, and so the patients could call in. And so there are lots of telephone lines or dedicated telephone numbers that persons could get information from. They also, another measure was a support group for staff, because again, we have to remember with this COVID, it is new, and staff, of course, have been affected, and so our midwives particularly need that support, that psychological care, not only for the clients, but for the staff as well. It also another measure that came into fore and was very active in maintaining the COVID contact tracing and customer service. And of course, like everything else, because COVID is new, we have to put in quality improvement training so that we would be able to monitor and learn from the COVID experience. So I want to particularly thank those persons who were interviewed in Trinidad from the hospital, initial AR, the midwife, from the community, the district health visitor from the County Medical Officer's Office, MWS, and also in the leadership position, BAP, our National Advisor for Nursing Services. And just to say that the interview was done by Ms. Deborah Lewis, and I am just presenting. Thank you very much.
Thank you, Mrs. Rollo. Just a reminder to the participants, so you can please place your questions in the chat. We have a question and answer segment at the end, and we will address your questions then. At this point in time, we'd like to welcome to make a presentation Miss Virginia Camacho, who is the Regional Advisor for Reproductive Health. Regional Technical Advisor, sorry, in Sexual and Reproductive Health. Camacho.
Sorry, Dr. Camacho, do you have a presentation? Would you like to share your screen?
Yes, I will.
Oh, okay, sorry.
Let me share my screen.
Okay.
I
Just
hope.
get you. Okay, good.
Okay. So let me share. Okay. Okay, so let me share. Where's my screen here? Okay. Okay, thank you. But I'm very sorry. I would like to really apologize because I was late, but this is because for some reason the link didn't work. So I couldn't get into the meeting until Pilar rescued me and I was able to get into the meeting. So my apologies for not being on time. The idea was Deborah requested me to provide with some introduction about respect for maternity care, considerations for maternity settings in the times of COVID-19, a conversation with Caribbean midwives. So as all colleagues just presented the results of the survey on respect for maternity care that was undertaken in the Caribbean, my idea now is to just let you know that all this work was supported by the Regional Task Force for the Reduction of Maternal Mortality, in which UNFPA is the technical secretariat. And as part of our work, our mission is to promote interagency collaboration to implement maternal mortality reduction, maternal neonatal health policies and programs in the Latin American and Caribbean region. Also, GTR has an important focus on maternal health as a high-level human right, and promotes respectful and quality maternal health care based on the best available evidence. For this work, within the GTR group, we, UNFPA and JPIGO, we are the co-leaders of the working group on respect for maternity care in Latin America and the Caribbean and within the GTR work. So this work has been shared with JPIGO, with my colleague Veronica Reyes, who was part of, who provided some of the training on this work. And we have provided all the forms and on the, for the survey on respect for maternity care. So you were able to carry out this research. Just to, and based on what I just heard, I think it's important for me maybe to highlight what respect for maternity care is, and it focuses on dignity, rights and gender equity. Emphasizes the fundamental rights and needs of women and newborns, focuses on the individual and the interpersonal dimension of care, and ensure participation of women, families, and communities. This is the respect for maternity care charter on the universal rights of childbearing women that was developed by the White Ribbon Alliance. So this is something that is part of our work and leads somehow the work on respect for maternity care. Also, respect for maternity care includes the use of evidence-based practices. So some of you just presented what's going on with each of these practices. based on the findings you have from the survey. So I think it's important to go back and look at which are these evidence-based practices. So first of all, respect for beliefs, tradition, and culture, the right for information and privacy, the right to have liberty of movement during labor, the right to choose and have a companion, the right to choose the position for childbirth, keeping mother and baby together. Also, you also mentioned during your presentations that the COVID pandemic has brought new challenges for the provision of evidence-based maternity care. And this is right. So accompanying women during childbirth in many settings, hospitals, maternity wards is not possible in the region, right? Separation of mothers and babies is common right now. There is an increased number on C-sections without allowing women to, to be able to have a normal delivery, for example. Also women COVID-19 positive have, it's a lot of issues related to breastfeeding, for example. Particularly at the beginning of the pandemic, this was really, a huge challenge for providers, but also for women, particularly for women. And services are not, I don't know, what some of you just mentioned some challenges with the maternity wards and the possibility of really having, the companion during labor and childbirth, because infrastructure is not possible. So if this was not possible before the pandemic, imagine now during the pandemic. It's very difficult for countries, for countries in the region to really ensure, all these principles of respect for maternity care. In some cases, I would say that this is not related to, to the evidence that we have with regard to COVID-19 and management of pregnant women during pregnancy, labor, and delivery, because WHO, has reassured that we should continue with all these respect for maternity care practices, and that we should ensure, a positive experience during labor and childbirth, even during the COVID-19 pandemic. However, this for our region has become a real challenge. And in some cases, it's because there's not sufficient still organization of services to address pregnant women and COVID-19. In other cases, it's because there's a shortage of staff, shortage of resources, particularly personal protection equipment for providers, but also for companions. So to really, carry out all this work in the region, what we did to start this work, we really organized 2 GTR consultations, first with Latin American countries, Spanish-speaking countries, and then that was done in September 2016 in Panama. And we had 72 participants from 11 Spanish and Portuguese-speaking countries. And then in Port of Spain, Trinidad and Tobago in November 2017, we had 24 participants from 7 English and French-speaking countries, including Haiti. Some of you are here in the meetings. The meeting was in Trinidad and Tobago, and some of the colleagues that just presented were part of the meeting that we held in the Caribbean. So respect for maternity care in the Caribbean, and following our Caribbean workshop in 2017, UNFPA and JPIGO, as said before, we are co-leaders of this GTR working group, in consideration that little was very documented of the situation in the Caribbean because no countries participated in the international survey of 19 countries in 2012. The CRMA president and other midwifery leaders attended the 2017 workshop in Trinidad and Tobago, and several GTR members had ongoing successful collaboration with CRMA, particularly UNFPA and Tobago. So CRMA was asked to carry out the survey you just heard, right, about during this webinar, and I appreciate all your presentations and the recommendations that you have provided during your presentations today. So thank you, and again, my apologies for being late, but it was totally, beyond my will. Thank you very much. So I'm open to have any discussion. I had some questions related to, well, we have now the data. We know the situation of respect for maternity care in the Caribbean. We know, our weakness. We know the opportunities we might have in order to really improve the care and ensure that all women have the right to have access to all these evidence-based methods, to be treated with dignity, and to exercise their human rights. But also, we are aware of the challenges that the COVID-19 pandemic poses. And I think that we really need to ensure that our discussion really provide some insight in order to address the challenges that the services, but also the midwives and other healthcare providers, such as OBGYNs, doctors, and nurses, midwives are facing, during this pandemic, which we know that will stay for a while, and will stay for a while or forever. But we need to do something about all the findings. So my suggestion was to prioritize based on the survey findings, and then to see what's going on. I heard some of you, really pointing out to the challenges related to RMC that some Caribbean countries are facing right now. So, but as said, we need to really identify what can be done, and how we, UNFPA and other partners, can really support the work on respect for maternity care during these challenging times. So I would like to hear more about that. What can we do? What can be done, and how can we really support the work and address all these challenges? Thank you very much.
Thank you very much, Dr. Camacho, for that insightful presentation, and I know it was well received by our participants listening. At this point, we will have Dr. Curtis make her presentation on respectful maternity care during COVID times.
Can you hear me?
Yes, we can.
Mr. Screen sharing?
Yes, it is.
Thank you. Okay. Good evening, everyone, again. I can bring up my slideshow. Okay, so Dr. Camacho, unbeknown to you, I think that your presentation was really at the right time. Let me take off my video. Your presentation was at the right time because I think it flowed very well with the presentation that went before. So I was asked to talk about respectful maternity care and how it affected the COVID environment. And I think a lot of our presenters thus far have really highlighted that. And so this presentation is going to be short. I made it so because I had a preview to the presentations. Dr. Camacho just shared this poster from the White Ribbons Alliance for Safe Motherhood that speaks to the 7 areas of respectful maternity care on the universal rights of the childbearing woman. Now, if this poster is not familiar to you in your area, if there are any nurse supervisors on the chat, or you should take down the information, because this information should be information that every midwife should have. And even the clients should know what are their rights. And as you heard in the presentations, a lot of the clients are not asking or not demanding respectful maternity care because they are not aware that it is a right. It is a right for every woman. So when we speak about respectful maternity care in a COVID environment, you know, the word for in the COVID environment now is PPE. Well, the PPE for me is providing personal experiences for the mother during her childbearing, antenatal, intrapartum, and postpartum period. So as a couple of the presenters before me said, RMC goes beyond the prevention of morbidity and mortality, all right? We have to do more than just say, okay, well, she came out okay at the end, right? We have to, one of the rights is to treat everyone with dignity and respect. And one of the ways in the COVID environment that we can achieve this is through education and communication. A lot of the women are afraid at this time, and they need to be educated a little bit beyond the washing of hands, wearing of masks, and social distancing, because they are carrying their baby, they are concerned, and so they need a lot of education, communication, and encouragement. We should ensure that the healthcare is at the highest attainable level of health. So every country might not be doing everything, but we must be sure that we are doing our utmost best at the highest attainable that is possible for you. So in other words, we don't want to water down and we don't want to scale back services that we already have access to, right? So we have to ensure that the woman is getting the best care. Another point in the rights of the woman is everyone has the right to the liberty, autonomy, and self-determination and freedom from arbitrary detention. As we heard, that arbitrary detention is not something that we have seen in the Caribbean, but one of the things that came along with COVID is the social distancing. So we are now social distancing from our clients, and that will not give us that client a positive personal experience, particularly in labor or in the antenatal period. So we must continue the physical contact, but with ensuring that we ourselves are protected, right? We must do our clinical examinations to ensure that the woman is progressing normally in her pregnancy. Care, and we must continue care as normal during the provision of the maternal care. We must pay extra attention to infection control measures. So therefore, because in most of our countries, we are not testing all of our pregnant women. So therefore, we must treat everyone as if they may be COVID positive. So we must protect ourselves, but at the same time, ensure that the woman is getting the utmost care. So how do we do that? One of the ways is to allow the support person during the labor and childbirth and postpartum period, because if you're wearing a glove, that is not going to give the person, the woman, a positive personal experience. So if her husband is there or her mother is there or whoever she wants to be in there, that person will be there holding her hands, rubbing her back. So she will still be getting that experience that she needs, that will give her a positive experience during that laboring time, even though the midwife might not at that time, might be giving her a little social distancing, right? So yes, when that patient is in labor and she is blowing, she might not keep that mask on. So you have to keep on your mask and keep your distance, but that support person is not gonna mind. They're gonna be right there in her face and doing what she needs to be done. So do not reduce monitoring and supportive care during labor and childbirth or the postpartum period. In some cases, we've seen augmentation of labor without obstetric indications. And the rationale for that was to move the woman through the labor ward in a quicker manner. Well, most times when we augment without obstetric indication, we end up with a cesarean section. So the woman is going to stay longer anyhow. So we would want to avoid that at all costs. The woman should be allowed to give birth in the position of her choice. And we know that in most of our institutions, this can be an issue. One, because of the delivery beds. Two, because of space. But in the COVID environment, if you weren't doing it before, the likelihood is that you won't start at this point. But if you were doing it before, in a COVID environment, what we are saying is that it should continue. Every child has a right to be with their parents and guardians. So therefore, we should not be separating our dyad, the mother and the baby, at birth. I know initially the research was not there, but there is nothing to support that the woman should be separated from her newborn, except for the fact that if the newborn had to go to the NICU for whatever reason. Pregnant women with severe acute respiratory illness need to receive specialty care. So we must ensure that we have dual management of that client. Do not give up your client to medicine to take care of the client. There should be dual management, ensuring that the woman and her newborn is receiving that maternity care as well as her medical care. And we heard all of the other options during the presentation. So I thank you, and I think this is the end of the presentations. And before I turn it back over to Kathy Ann, just to say that we have been putting a link in the chat where persons can access the evaluation of the program tonight. And in order to receive your certificate of attendance, you will have to pull out that link. So I'm going to put it back in there again at the end of the chat so that you can see it. And thank you very much. Over to you, Kathy.
Thank you, Dr. Curtis, for your presentation. So this brings us more or less to the end of the presentations. Excellent presentations by all the presenters. The lessons learned is one that is shared around the Caribbean. So each one learned from the other. And without further ado, because I know time is of essence, we will now go over to Mrs. Franca Oliveri Andrews, who would lead us through our question and answer segment.
Unmute your mic, Franca.
Thank you, Marcia, and thank you, Katian. Thank you, everyone, for very much for your presence and participation tonight. We had a few comments and also a few questions, and I just want to go through the comments very quickly. The first person said, thank you very much for acknowledging the few male midwives in the system. Next person, I'm happy at this point, I'm happy the point of lack of policies and guidelines was mentioned. Another one, the denial of food and drink during a statement. A denial of food and drink during labor is significant. Perhaps the rationale should be explained in detail in terms of the process of digestion during the prenatal period. This is because labor is considered normal until a challenge occurs. Please stop me if anybody wants to intervene and make comments. The first question, can we have copies of the presentations? The second question, Shirley, you want to?
Okay, sorry. Yes, the question, the presentations will be available on our webpage in probably a week or two, more so 1 week, I think, because we have all of them. So yes, those presentations will be available, as well as the persons that presented in-country reports will be available as well.
Thank you very much, Shirley. I continue with questions. Another question, these findings are ongoing, and at what point will something tangible be done to address these issues? Although in some of the presentations, we saw some improvements after the survey was done and the recommendations were made. Anybody would like to comment?
I think also that we need to also remember it all starts with us. So in whatever little way we are doing within our practice, we can make a difference. So just think of all the issues highlighted, what we didn't think were mistreatments, which are mistreatment of the woman. We just need to correct that in our practice, and each one does that, then we will move along quite nicely. So I think we need to just look personally at our individual practice to put things in place when it comes to respectful midwifery care, respectful maternity care.
Thank you, Marcia. Shirley, I'm seeing.
I agree with what Marcia is saying. I think if each one reach one, I think we will spread, it will even spread faster. I think we wait a lot of times for things to come from on top to come down, and that is not necessary. We are midwives. We say we have autonomous autonomy of practice, and so therefore we need to use it in the small ways before we even go to on the grander stage.
Thank you very much, Shirley. Another question, does any country represented use wireless monitoring during labor, allowing the woman freedom of movement? Anybody can respond to that question. Does any country represented use wireless monitoring during labor, allowing the woman freedom of movement?
For the Bahamas, at this time, no, we don't. have wireless monitoring of our maternity clients?
So right now, there are no countries in the Caribbean that have wireless monitoring.
And can I just say that if you have a patient that is in normal labor, continuous monitoring is not necessary. There's no need to strap that woman down for 6 to 8 hours. If she's in normal labor, you will do intermittent monitoring for a set period of time. And that is where, as midwives, you collaborate with your obstetricians and you set a standard for your unit as to what that period of time should be. Should you monitor the patient for half an hour, for 15 minutes, and then allow her to move around for the 45 minutes and then come back and monitor her again? But if the woman is in normal labor, think about it. Why do we need continuous monitoring?
Franca,
Yes.
for you.
And
The person said wireless, and I'm thinking as well, sometimes what happens is that the client is moving around in the labor room, and I agree with Shirley as well, but we use the Doppler just to listen to the baby's heartbeat intermittently while she's walking around in the labor room. She doesn't have to go up on the labor bed and have her FH assessed. While she's walking, the midwife can just take her Doppler and assess the fetal heart rate.
Exactly.
So I'm not sure if that answers this person's question, but that can be done very easily.
thank you for your response. Next question. Burnout of the maternity staff due to short staff is repetitive. Something needs to be done. I think sometimes this is more than us because we always make representation for more staff based on the the number of patients we have, the type of patients we have. Anybody would like to make a statement? Give me an idea.
Well, all we could say is true, but where would we get those persons from? If everybody is short of staff, if I go down to Trinidad and get them from Trinidad, then Trinidad will be short. If I go to St. Lucia and get it from St. Lucia, then St. Lucia will be short. So every place is short. So it's just a matter of, I guess, coming up with different recruitment strategies. And one of those is catching back up again is direct entry midwives. Because when you have direct entry midwives, they are not in your nursing pool, therefore they stay on your maternity ward.
Right. Marcia, you wanted to say something?
No, I agree with Shirley in that shortage of staff is bigger than all of us. But we just need to utilize the staff we have to the best of our ability to avoid the burnout. We need to ensure, as we said before, the psychological effect. We can't downplay that enough. That a lot of emphasis goes on psychological for the patient, the clients. What about the staff? We need to also remember the mental health and well-being of our staff.
And I think this year too, it was felt more so because there was a delay in getting our student midwives. You know how we anxiously await them to finish their training, yes, for them to be absorbed. But with COVID, there was a bit of a delay with that as well. So the midwives who had to remain, and some of them even had to give up vacation at the point in time when COVID, now started. So yes, they will be the effects of it.
I know another strategy in Trinidad is that many of the schools and universities are now going to do training for midwives. So in maybe 2 or 3 years, we'll have more midwives, but then we have.
So y'all have something to share?
Karen also, who's leaving the practice also. So it's just replacing the senior citizens, the senior midwives.
It's the senior citizens, yes.
Another question, how far are we with having the client's spouse supporting the mother during labor and delivery? What are our plans in ensuring that staff are not burnt out? So those are kind of two questions there. But I know a lot of people have identified that staff are, relatives, spouse are allowed in the birthing center with the pregnant woman. I don't know if it occurs in all of the countries, all of the Caribbean countries, but I know Marcia
No.
mentioned it in her presentation.
That occurs in Trinidad, in all the institutions, public and private in Trinidad. I don't know,
Anybody
Diana.
countries would like to make comment?
I think in the Bahamas, it's only in the private sector.
Yes.
I think it's because in the public sector, it's a matter of spacing.
Yes. And
Franca?
we're looking at renovating in the future. So hopefully when the renovation process is completed, we would have, better spacing. And the plan is to be able to allow someone in with that maternity client for companionship.
Franca, for you.
Yes.
In St. Lucia, in 2019, when we conducted the survey, partners were not allowed in our labor rooms. But right now in 2020, they started introducing the partners into the labor room with, yes, with some kind of limitations. And now COVID has impacted it a bit. So they recognize there's a need for training for the partners before they come into the labor room, because they will need support. The midwives do not want more than one client to deal with. So what we're working on is actually providing the support for the support person as well. So they are not overwhelmed with what they see, and they are better partners and better supporters to their partners, if you understand what I mean.
Yes.
Just to say, in Grenada, we allow the partner to be there, or the patient's mother, whichever one she wishes to be there, we allow. We were doing it before COVID, and even during COVID, when we had limited visitation, we were still allowing them just to come and give a little support only for the delivery process, not during labor. Yeah, and we continue. So even now we do it. So it's something we've been practicing for years now, and we continue to do it. It's very beneficial for the laboring woman.
Excellent. Any other contribution from other countries? What's happening in your country? Jamaica, we hear from Jamaica? Somebody,
All right, yes, Franca. So for Jamaica, our practice is not that where we allow the companion to be in the labor room. And it has a lot to do with the setup of our delivery rooms. They are just mostly like screens made from fabric. So it doesn't allow for total privacy, and you wouldn't want invasion of another client's privacy. However, since the survey was done, I have had the opportunity to work at a smaller hospital where you really don't find more than 1 or 2 laboring women on the unit at any given time. I have had dialogue with the sister in charge of the unit, and I have had the opportunity, along with other midwives, to have the companion of the client's choice in the delivery room. It was a great experience. You could see the joy on the laboring mother, having her spouse there. And it allowed for the delivery process to seem shortened and everybody just happy. But then there are some persons at the same hospital as maybe the sister on duty on any given shift that is not so receptive of having companions being there. So it depends on the person in charge. But I think with education on RMC, and you over a period of time, we might find the acceptance rate going up. And hopefully some retrofitting can take place for hospitals, so we more have cubicles instead of with proper privacy, instead of just material parting 2 laboring women.
Thank you very much, Bobby Joe.
Welcome.
Did we hear from Grenada?
Yes,
We did. Okay.
yes, we did. Mhm.
All right. And the second part of that question, what are some of the strategies that we can ensure that staff are not burnt out? Let's do that quickly.
Well, in
Burnout is
terms of
something-
Managers here with us?
Okay. Well, I was just gonna
Go
say
ahead,
that
Bobby
in
Joe.
terms of staff being burnt out, having staff shortage in its in the intensity that we do have, it's kind of hard not to have the staff burnt out. But I think what supervisors, ward managers can do too is at times go to the units and get involved. Give them let the midwife on duty get a little rest break, and you motivate them, give them little incentives, you know, just to let them know that you are so appreciative of them going beyond the call of duty. And sometimes you just go in as a supervisor, as a ward manager, and you just work and work and you work with them. It will help. It will help.
Very good contribution, Bobby Joe. Any other?
No, I think that response was adequate.
Yes, okay. So now that this is my response, my question. Now that we have done the survey, we have done the presentation, what is next in terms of educating our staff the RMC and beyond?
Okay, I think I'll answer for CRMA. For CRMA, what we plan to do is to roll out a video for circulation within the Caribbean countries on respectful maternity care. Something that can be used not just for the midwife, but also for the client, so that she is aware. Another, one of the other strategies is we want to create a poster related to respectful maternity care. And I almost think that poster is now redundant, looking at the one that Dr. Camacho just put up in her presentation. That is an excellent poster that will speak more picturesquely more than verbally, because you know the clients, they will see pictures more than they would read in most cases. So yeah, but basically to create posters that can be used to remind the midwife, to remind the client of their rights as they and the rights of the woman as they go through the management.
Thank you.
That's our beginning. Yeah.
Thank you, Julie. I did something and I'm not seeing you all, but any other contribution from any other association or country?
Franca?
Yes? Are you hearing me?
Yes, we are. I
All
guess
right.
there are no further comments. So.
All right, so therefore then I pass it on. Thank you very much for the contributions made tonight and the questions and comments stated. So I'd like to pass it back to Katian, who will do the wrap up. Thank you all and have a good night, and I'm now going to say reach home safely. But you are
Just stay safe.
Katian?
I don't think
Yes.
anybody hearing me.
You're-
I wanted to just say something.
Maureen, I'm
Yes.
hearing.
Oh, okay.
Are you
Go ahead.
hearing? Right. What I wrote about the food and drink simply because sometimes,
Katian?
are you hearing?
Yes, loud and
Right.
clear.
Simply because sometimes in midwifery we forget our general
We're not
training.
hearing you, Kathy-Ann.
No, Maureen is on the.
Somebody is speaking, yeah.
Oh, I'm not hearing her.
Right. You all hearing now?
I'm
Yes.
hearing you, Maureen.
Yes, go ahead, Maureen.
Maureen?
She get cut off.
Unmute your mic. Right,
Okay, right.
right.
You know,
Mhm.
sometimes, you know, we forget the little bit of general nursing. And sometimes you tell people they have to starve, but they don't quite understand why I must not eat. And therefore, we need to explain this aspect of denying food and drink to them a little more, because sometimes they think that maybe we don't want them to eat or drink for whatever reason. They're not really sure why they don't eat and drink. And many people have to undergo surgery and they're still not sure why they have to starve from 12 midnight. So I think we need, before they think that this is disrespect, we need to explain it a little bit more so that they will understand why they must not eat and drink. And they wouldn't think that that is a form of disrespect. So that's what I needed to say. Thank you.
Thank you very much, Maureen. Katian?
Yes, you're hearing me?
Yes.
Okay. So once again, we want to say thank you to the presenters for doing an excellent job in their presentations and enlightening us on what transpired with the survey on respectful maternity care in the various countries. Moving forward, we hope that the recommendations put forward by each country will be taken up with the persons, the respective persons who are in charge, and therefore we can push midwifery further along. For those countries who have not yet gotten the support partner to participate, we hope that they too will eventually have the support persons with them. The challenges of burnout, staffing shortage.
Oh, no, mute your mics, please. Sorry.
Okay. So the challenges of burnout, staffing shortage, it's something that we have occurring on many fronts, and at one point we will be able to address that situation with our workforce planning. Somebody has their mic on.
Hold on, I'll try to mute it for you. Go ahead. Go ahead. I'll try to mute it. I don't know.
Right. We trust that the questions that were put forward were ably answered to the satisfaction of those who posed those questions. The presentations will be available on the website. The website is Caribbean Regional Midwives Association.com. You can go on there. It is still being populated, but we will have on the education page links to all the various webinars that have taken place thus far. So once again, I'm passing you on to Shirley, Dr. Shirley Curtis, and I am saying thank you for taking that time out to be present here to help us in this fight against getting midwifery in the Caribbean region where it ought to be in every single island.
Thank you very much, Kathy Ann. On your screen, you would notice that we have a flyer just to inform some and to remind others that our annual general meeting will be held October 7th and 8th, 2020, virtually, the new norm, from 6 to 9. Now that is 6 o'clock now, not 7 o'clock. It will be done from 6 to 9 because it is the AGM annual general meeting and we have a little bit more to do. So the meeting runs from 6 to 9. Now on the 7th will be our educational night. You do not want to miss it. Some very interesting and very motivational topic for midwives will be discussed. On the 8th, the link for that will come from your association persons, because that will be our business night. Okay, the 7th is open. The 8th, we will be sending out that link to the various associations, and all midwives within those associations are invited to attend. So we look forward to seeing you on the 7th and the 8th of October, which is in what? 1 week, 2 weeks, right? Next, the Google form link for your evaluation was put in the chat several times tonight. So we would ask that you all click on the link, fill out the form. Today is Tuesday. The teacher and me is gonna come out. You have until the weekend to fill that form out. If you do not fill out the form, the secretary will not send you a certificate of attendance for tonight. Okay, so you have to fill out the form in order to get your certificate from the presentation. So if you go to the chat, the link is there, just click on it or highlight it, save it if you're not going to do it tonight. All right, I like to do roll call. We appreciate all of your attendance, and we had up to 200 attendees on the chat tonight. So I saw Antigua, I saw St. Kitts, I saw Trinidad, Barbados, Bahamas, Guyana, Jamaica, St. Lucia, Suriname, and Grenada, on Trinidad and Tobago, by the way. And if you did not hear your country, please type your country's name in the chat. Thank you very much, and good night to all.
Good night.
Hawaii, Hawaii. Somebody from
Good night.
Hawaii and Belize.
You saw Hawaii too? Oh,
Hawaii and Belize.
Hawaii. Hi, Hawaii.
On the UK, there's Lydia Suarez she has her hand up forever. I'm not sure.
Who's that? Somebody's hand was up?
Yes, has been up for a little while. Lydia Suarez.
Just a question.
Still up. I don't know why.
Lydia, is there something that you want to say?
Good evening, this is Lydia Suarez speaking.
Yes, Lydia.
No,
Turks and Caicos.
I just say there was an excellent.
Okay, thank you very much.
Thank you.
Turks and Caicos was there too? All right.
Yep.
Hi, Turks.
And UK, of course. USA
TCI.
and UK.
And then USA and UK. Wow. Awesome. Hi, Asita. Are you back in Jamaica? I see Asita on the chat.
You see how good technology is? Could we ever have a meeting with 200 delegates?
Hello.
Oh.
Come on, I mean,
Hello.
technology.
That's right. That's what
Technology.
COVID, that is what COVID,
That's right.
let me stop recording.
Yes,
That is what
yes.
COVID will do.
Yep.
True.